Hello, welcome everyone to session 7 of the Oxygen Therapy and Critical Care case-based series with Dr. Ananya. Today's topic is defining ARDS, and with us we are pleased to have as co-panelists Dr. Hussein and Dr. Rima. Dr. Hussein Indris is from Gondar University Hospital, and Dr. Rima Patel is part of the Global Anesthesia Surgery and Obstetric Collaboration. Before we begin, just a couple of reminders. Throughout the session, we will be using the chat function for question and answer. This button is at the bottom of your screen, so please send all questions through the chat and feel free to introduce yourself. If you have any IT issues, send us a message through the chat. And this session is being recorded, so your attendance is consented to being recorded. Thank you. And with that, I'll hand it over to Dr. Ananya to start us off.
Well, thank you, Alana, for a nice introduction. As you said, today is our 7th session. It's going to be on defining ARDS. Welcome all for our session. We have 2 panelists as said, and so today's session will be based on a case scenario which has been given on our last session. You may remember Mr. T, who is a 46 years old man who presents with hypoxemia and respiratory distress, and our objectives are listed below. You can see it on the orange background, and so we will be defining respiratory failure. We'll be going through the types of respiratory failure and how to define hypoxemia using pulse oximetry or arterial blood gas analysis, and we'll list the 4 key criteria for the definition of ARDS. And whenever arterial blood gas analysis is not available, we'll be able to apply the Kigali modification to diagnose ARDS. And through our this case-based discussion, we'll describe what mild, moderate, and severe ARDS is. And we'll describe the pathophysiology that occurs in ARDS. And we'll list out the principle of management, including lung protective ventilation. And we'll be able to understand parameters which will help to improve oxygenation, which will help to improve carbon dioxide elimination. And we'll apply, after understanding this, we'll apply how to improve oxygenation through certain intervention and apply those interventions to improve outcomes in ARDS patients. So I will start the session by updating the case, and following that, Dr. Hussein will take over to go through the first parts of our session today. So as you might remember, in part 6, we have learned about Mr. T, a 46 years old man who presented with hypoxemia and respiratory distress. Unfortunately, Mr. T was found to be positive for SARS-CoV-2 virus, and his clinical course progressed to respiratory failure requiring ICU admission, intubation, and mechanical ventilation. His vital signs in mechanical ventilatory setting are as follow. So vital signs are heart rate 102, blood pressure is 97/51, respiratory rate is 35, temperature is 7.5 degrees Celsius. Saturation of oxygen 90%, and mechanical ventilatory setting AC mode, volume control ventilation, FIL 200%, respiratory 35, tidal volume 400, PEEP is set 14, and peak inspiratory pressure is 14. So keeping in mind with this case, now we'll go to some update regarding respiratory physiology and failure, and we'll have this session going by a case-based discussion. So the first question is to come here, and for this I'll invite Hussein to go along with some of the questions coming next. So Dr. Hussein, can you take over with the first question, please?
Thank you, Dr. Ananya, for the introduction. Dear participants, you'll have 30 seconds to try your suggestion as why do we breathe. So after that, I will proceed. Our participants, you can participate by writing on the chat box. So why do we breathe? Basically, you all know that oxygen is a very important substrate for our life in the process of aerobic respiration. As you know, any food that we take will be converted into glucose, and this glucose will undergo a series of metabolic process to produce an ATP, which is a very important energy source for the normal functioning of our cells in our body. So during this process requires an oxygen in its last cascade, especially on the electron transfer that occur in the mitochondria to produce a lot of ATPs. So this electron transfer is done or mediated by oxygen. So to fulfill this oxygen, we need to respire. And into the process, there is a production of carbon dioxide, especially during the conversion of glucose into pyruvates and into the NADH. There is a synthesis of carbon dioxide, as well as in the Krebs cycle, whereby the end product or the water and the NADH and FADH2 are produced. There are plenty of carbon dioxide produced as waste product. So this waste product should be removed from our body. So this whole process is mediated by the respiration, which is undertaken by our lungs. So this is the basic or the that we need to breathe.
Yeah, thank you. So we can also see the video.
When you breathe in, air enters your nose or mouth and passes into your trachea or windpipe. At the carina, the trachea divides into two bronchi, then branches into smaller bronchioles. The bronchioles end in tiny air sacs, or alveoli. Here, the oxygen in the air you inhale passes into the bloodstream, and carbon dioxide from your body passes out of the bloodstream. The carbon dioxide is expelled from your body when you exhale.
Yeah, I think so. Yeah, it was well described why we breathe. We have seen also in chat box that we breathe for the sake of oxygenation and ventilation, and we all agree with that. So let's proceed with the next set of questions, Dr. Hussein.
Okay, thank you for your participation again. So the next question is, which one of the following statements about respiratory failure is incorrect? So you have also 30 seconds to choose one of the choices, which one of the following is incorrect. So you can choose among the polls. Participants, please write what you feel is incorrect regarding respiratory failure.
Yeah, I'm following the poll and like so far 20 participants, almost all of them are saying B.
Yes, and some of them said the first, some of them say the second one.
Yeah,
Yes,
only one individual saying A and one saying B, I guess.
Yes. Yes, we are done with our 30 seconds. So from the poll, you have seen that most of you have chose D, and one individual says A and one says B. So let's see the answer each one by one. So the first one said respiratory failure is a failure of gas exchange, either oxygenation or carbon dioxide elimination. Yes, it is a correct statement. As we have said, the function of this respiration is to deliver oxygen for cellular respiration and to excrete the byproduct carbon dioxide from our body. So any abnormality in the delivery of oxygenation or in the excretion of carbon dioxide from our body is called respiratory failure. So the second one is B, respiratory failure can be acute or chronic. This also is a correct statement. Yes, some diseases may result in acute rapid failure of this respiratory function, and some diseases also may give prolonged time to result in this respiratory failure. C, it says respiratory failure is a syndrome rather than a disease. Yes, this is also correct because it says syndrome, that respiratory failure is not a single entity, but it is an end result of a lot of disease process which can directly or indirectly affect our respiratory system. So it is a syndrome rather than a single disease entity. And D, it says respiratory failure usually resolves on its own. This is an incorrect sentence because respiratory failure is usually, it is a fatal process unless we intervene, unless we deliver appropriate therapy, a self-limiting or a self-resolving condition by its own. So we need to give due attention for a patient having respiratory failure. And E, it says patients with respiratory failure can exhibit tachypnea, hypoxemia, and hypercapnia. And this is a correct statement. As you said, yes, respiratory failure is manifested as a symptom of tachypnea, signs of respiratory failure, and signs of objective hypoxemia and hypercapnia, or an increment in carbon dioxide level in the body, are some of the signs of respiratory failure. So having this, thank you for those who answered the correct answer, that is D. D is the incorrect answer. So let's proceed to the next question. It says list the types of respiratory failure. So the participants, you have also 30 seconds once again, and your involvement is very welcomed. Please use your time. It's better to mention by names or in words rather than by saying type 1, 2, 3, 4. Rather than saying that, please write the types. Thank you. Yes, a lot of people are answering. CSI, this 2 says type 2, type 3, type 4.
Yeah, almost 40 seconds.
Yes, thank you for your participation as well. Some of you have mentioned by names. Yes, there are basically 4 types of respiratory acute respiratory failure. As we have discussed, we have defined what acute respiratory failure is. It is a loss of the ability to ventilate adequately or to provide sufficient oxygen to the blood, and or the ability to remove carbon dioxide from the body is called acute respiratory failure. And based on their mechanism, basically they are classified into 4: type 1, 2, 3, and 4. Type 1 is also called hypoxemic, whereby the primary or the underlying disease or the underlying problem is the problem in delivery of oxygen to the blood and thereby to the tissue. Anything that affects the diffusion of oxygen from the alveoli to the blood is results in hypoxemic respiratory failure, and is defined as an arterial oxygen tension less than 50 millimeter of Hg on room air is called hypoxemic respiratory failure. And the type 2 is also called hypercapnic or hypercarbic or ventilatory respiratory failure. This is failure in the elimination of carbon dioxide from the blood. It is a problem in elimination of carbon dioxide as compared to hypoxemic. So the end result will be an increase in blood carbon dioxide level, usually greater than 50 millimeter Hg of carbon dioxide in the artery. If the exact numbers may differ based on specific patient types who are chronic carbon dioxide retainers, whereby the level may be higher to define this hypercapnia. Usually the causes for hypercarbic are either deficiency in central nervous system, which resulted in poor respiratory drive, or in an impaired neuromuscular function that impairs the proper ventilatory function. And the third type is called perioperative respiratory failure. This type of respiratory failure is basically a form of type 1. That means it's hypoxemic in its origin, but why it is subdivided in its own is it is common apart from other causes of hypoxemic respiratory failure. So usually the causes or the mechanisms are due to atelectasis of the dependent lung, due to pain, anesthesia effect, drug or anesthetic drug effects, and so on, will result in hypoxemic respiratory failure in a patient who is in a perioperative condition. So this is the third one. The fourth one is type 4. It is the result of due to the inability of the cardiovascular system to deliver the appropriate oxygen requirement to the peripheral tissue. So based on this, the treatment and also the treatment methods may differ based on this classification, which will be discussed later on. So having this highlight of types of respiratory failure, you have seen the case prior as introduced by Dr. Ananya. So what type of respiratory failure do you think that Mr. T have? What type of respiratory failure? So you can also put your answers on the chat box. 30 seconds again. And why do you say so? You can also include your reasons. I'm not seeing any answer from the participants.
Maybe to say something about, Mr. Tize might have forgotten the case. So he's a 46 years old, presented with respiratory distress and hypoxemia, and he was diagnosed with SARS-CoV-2 virus, and his clinical, vital sign is as follows, and he's intubated and on mechanical ventilator. So the parameters are as you can see on the screen. So looking to his vitals and the ventilatory setting, and the fact that he's having CoV-2 virus infection and his presentation respiratory distress, which type of respiratory failure do you think is he having? Yeah, now we are having, people, yeah.
Okay, some says mixed type 1 and 2. A lot of others say type 1. Okay. And also mixed.
Yeah, I think most says type 1, and some are saying also mixed. So what do you say, Hussein?
Okay, can you scroll down, Dr. Ananya? Yes, most of you say type 1 and some says mixed. Okay, thank you for involvement. So as the cause or which type of respiratory failure can be dictated from the patient's history, physical examination, or general presentation, but exactly what type of respiratory failure has a patient may need further determination of his blood gas condition. So our patient presents with acute onset of respiratory distress with possible suspicion of COVID-19 infection, and upon your monitoring, you have seen that his saturation is 90 and down with that mechanical ventilator. So based on this, we can say that the patient has type 1 respiratory failure, but still the patient might have a concomitant type 2 respiratory failure, which needs the determination of his blood gas levels with ABG analysis. So just the message is you can dictate which predominantly the cause for respiratory failure for a given patient is, but the exact confirmation needs blood gas analysis. So most of you who said type 1, you are right, and some of you who said mixed is also right, but it was better if you present your reason why to say mixed. Anyways, thank you for your participation.
Yeah, thank you. So almost we have gone through the first part of our session, which is about defining respiratory failure and the type of respiratory failure and how to differentiate between those types. And now the second set of our objectives is about defining hypoxemia. So we have also a set of questions. So Dr. Hussein, can you go through them as well?
Okay. Thank you. So as you can see from the screen, that the patient is put on a monitor, ECG, pulse oximetry, blood pressure, and so on. So it's reads pulse of 105 and the saturation 88%, and BP 106/60, as you can see, in carbon dioxide or in thyroid carbon dioxide level of 31 with respiratory rate of 32. So how is hypoxemia defined using pulse oximetry? That means, does this patient has actually hypoxemia based on this monitoring result? So you have also 30 seconds to answer for the first question. That's how hypoxemia is defined using pulse oximetry. When do you say the patient has hypoxemia? By using your pulse oximetry. Okay, thank you. It is 30 seconds now. As you most have said, less than 90, less than 90. Yes, I agree. So using pulse oximetry, which measures the peripheral oxygen concentration of the peripheral oxygen concentration of the hemoglobin, the percentage of hemoglobin that's filled with oxygen. So if the pulse oximeter reads less than 90%, so you say hypoxemia, and you need to start administering oxygen using different devices or delivery devices of oxygen. You know them, there are intranasal cannula, or there are nasal prongs, or you may use a nasal catheter, or different types of face masks based on your patient response. So with the targets making in a normal adult to make the saturation more than 90%. With this, when the patient is having multi-organ failure, you may target a bit higher oxygen target, like more than 92%, or if more than 94%, you may consider. And in pregnant patient, also your target will be higher than the normal adult. That's between 92 to 95%. So the amount of oxygen that can be delivered by nasal cannula or nasal prongs, as you know, is up to 5 liters per minute, up to 40% of FiO2. It can be used in children or in adults as far as the patient is responding. And also there are nasopharyngeal catheters, okay, which you will insert deeper to the nasopharyngeal space with around 1 to 2 liters per minute, and they are said to deliver up to 60% of FiO2. This is used in infants and child as well. And also you may use face mask with higher flow, up to 6 to 10 liters per minute to deliver up to 60% of FiO2. You may also use a face mask with a reservoir bag that prevents rebreathing, and the flow can be increased up to 15. And this type of devices are said to deliver up to 95% of FiO2 for a patient. And also there are venturi masks, so-called venturi masks. These masks are specialized devices that can be set for a specific FiO2 level that you want, and it's color coded, so you can choose the amount of FiO2 that you want to deliver, and they may also deliver up to 60% of oxygen. So if the patient is not responding with this approaches, then further invasive airway and ventilatory treatment may be warranted, and this will be discussed in the coming topics, I think. So this is how you diagnose hypoxemia based on your pulse oximeter finding. And the next one is also, the question is, how is hypoxemia defined using arterial blood gas analysis? Yeah, so how do you define hypoxemia based on the ABG or arterial blood gas analysis? You have the 30 seconds as well for your trial.
I'm seeing so many of less than 60 millimeter of mercury.
Okay. Yes, now it's 30 seconds based on my timer. Sometimes the measurement of this peripheral oxygen measurement using this pulse oximetry may not be reliable, especially in severe hypoxemic conditions. So in these conditions, you may need to have an arterial blood gas analysis, which may not be available actually in most of poor limited setup. But if this is available, it's better to know. So the definition may vary according to the type of instrument that's used, but in overall, generally, the arterial oxygen partial pressure less than 75 millimeter Hg is considered as hypoxemic. And some of you say 60. Yes, there are, it differs from, as I said, differs from one instrument to the other. So 60 may be also the right answer, right?
Yeah, here the trick is the PaO2 level of 60 coincides with, peripheral saturation of around 90%. So in most institutions, they may take this as a cutoff point for hypoxemia. But also 75 millimeter of mercury is something in hypoxic range. If you draw the hemoglobin dissociation curve and see where it lies between the peripheral saturation of oxygen and the partial pressure of oxygen level, it may end up in something 94%. So anything below that we may consider it as hypoxemia, as it is not normal, it's not a normal. So when it is below 60, that's when we really need to administer oxygen and so on in most adults, okay? Because we tolerate saturation up to 90%. So, but the normal value is, as Dr. Hussein, you are saying, is 75 to 100 millimeter of mercury. So, yeah, this I think is an important point.
Thank you, Dr. Ananya, for further clarification. Yes. So as you can see, values from the ABG, we have a lot of parameters that we read from arterial blood gas analysis, including the pH, the arterial oxygen tension, arterial carbon dioxide level, bicarbonate, and others as well can be detected.
Yeah, so far we have then, two major objectives: defining respiratory failure and defining hypoxia. So we'll be now going to defining ARDS. So we will be starting with questions. Yeah, Dr. Hussein, it's yours again.
Okay, thank you. So what, I hope you all have heard about ARDS. So what does ARDS stand for? You have 30 seconds. That A, adult respiratory distress syndrome, B, adult respiratory disease symptom. You have a poll, so you can choose the correct one. You have a poll. Okay. Thank you. Yes. Almost one individual says A, adult respiratory distress syndrome. the other say acute respiratory distress syndrome. Yes, D is a correct actually acronym elongation, acute respiratory distress syndrome. When you see the history of this ARDS, basically it was noted in 1960s in soldiers, and so the military clinicians called it as a shocked lung, and later on the civilian clinicians changed the name into adult respiratory distress syndrome because they noticed it occurs in usually adults. But later on, the disease pathophysiology was also detected and noted in every age group, including children, adults, and elderly people. So the name was named as acute respiratory distress syndrome. So that is the current nomenclature. Acute respiratory distress syndrome is the correct name for ARDS. Okay. About 19 out of 20 people, 95% has answered it correctly. So the next question will be, then what does, how do you define ARDS? And, or when do you say the patient has ARDS? Okay. So what are the criteria to define the patient has ARDS? You have also, 30 seconds, and so you need to be, you can mention criteria that you know. What are the Berlin definition of ARDS, in other words? When do you say the patient has ARDS? I'm not seeing. Okay, probably they may be writing. Okay, time. We have 30 seconds lapse. So, okay, yes, as I said, a lot of people were writing, and I'm receiving acute bilateral opacity. Thank you for your trial, anyways. Maybe due to short time that I gave. So we have criteria to diagnose ARDS clinically. So that's criteria. The Berlin definition requires that at least 4 criteria should be fulfilled to diagnose ARDS. Then the first criteria is acuteness. I mean, the onset of a disease should be acute. That means it should be within 1 week of onset. The symptoms of respiratory disease, or if the patient has any chronic respiratory problem, then the beginning of this worsening should be within 7 days. It says this is the first criteria. The second criteria is the imaging finding. It says there should be a bilateral infiltratus by X-ray or CT scan, whichever is available in your setup. So this bilateral infiltrate should not be defined or explained by effusions, pleural effusions, or any lower collapse, or any pulmonary nodules. It should be infiltrate. Bilateral infiltrate should be demonstrated by chest X-ray or CT scan finding. And the third criteria says that these symptoms of respiratory failure should not be fully explained by the problems in cardiovascular system, which means heart failure with concomitant pulmonary edema or any fluid overload should not explain the patient's condition. In some cases whereby the patient is not thought to have risk factors for ARDS, we may need to objectively assess the patient's cardiac condition with the use of echocardiography to assess the patient's cardiovascular condition. Okay, so after ruling out that the cause is not cardiac, then this we say the third criteria is fulfilled. Then the last one and the most important one is the patient should have a certain form of hypoxemia, which is defined by the PaO2 FiO2 ratio, or which is the ratio of the partial pressure of oxygen in the artery divided by the oxygen, the fraction of inspired oxygen level. And the PaO2 should be read in millimeter Hg, or should be measured in millimeter Hg, and the FiO2 is measured, or its unit should be written in the decimal point rather than the percentage. So by dividing this, we will divide, or we will rate the severity of the patient's ARDS if these four criteria are fulfilled. So we can classify the severity of this ARDS based on the PaO2 FiO2 ratio as mild, moderate, and severe ARDS. So we say mild ARDS when the PaO2 FiO2 ratio is less than 300, but when it is more than 200, while moderate ARDS is a patient having PaO2 FiO2 ratio between 100 and 200, and those with a PaO2 FiO2 ratio of 100 are considered to have severe ARDS. So the management, their prognosis will differ based on this severity, as will be discussed in the management section. So these four criteria are called the Berlin criteria, or the Berlin definition of ARDS. So you have a case here, you to exercise how to calculate the PaO2 FiO2 ratio. If Mr. T has an arterial partial pressure of oxygen equaling to 60 millimeter of Hg with your arterial blood gas analysis, and your mechanical ventilator is set to deliver 80% of oxygen. So what is his PF ratio, or the PaO2 FiO2 ratio? So you have 30 seconds, calculate and write it on the chat box, your answers. You have, okay, 75. Very good. Okay. Okay. Yeah, most of you said 75. That is a correct answer. So PaO2 and PaO2 FiO2 ratio is, as I said, is calculated by the partial pressure of oxygen in the artery by measuring with millimeter of mercury and making the FiO2 into decimal. So the patient has 60 millimeter of Hg divided by 80% of FiO2 stands for, or means 0.8. So dividing 60 to 0.8 gives you 75. So based on this calculation, determine if Mr. T has mild, moderate, or severe ARDS. Okay, we have calculated that the PF ratio is 75. So which severity group the patient is categorized? Severe, yeah, a lot of, most of you said severe. That is a correct answer actually. Yes, we calculated the PF ratio is 75, and we said a patient with PF ratio of less than 100 is considered as severe ARDS, so the patient has severe ARDS in this case. Recall that the PF ratio is calculated from the finding of the arterial blood gas analysis, and we have said that this blood gas analysis machine may not be available in most of our setup. So how can we diagnose this ARDS, or how can we categorize the patient's severity in our setup in a resource limited setup where ABG machine is not available? So anyone who have experience or who know how to diagnose can write on chat box your answers. Okay, some says a Kigali modification, very good. And we use SpO2, yes, very good. Yeah, so we use the Kigali modification, whereby we will modify the criteria that will be tailored to our setup. So the Kigali modification modifies that. Recall that from the Berlin definition, we say the onset should be acute. Of course, the Kigali classification also considers this should be an acute process. The second one, it says there should be a bilateral infiltrate by using X-ray or CT scan, it says. But in most of these limited resource setups, CT scan may not be available. So in place of the CT scan, the use of ultrasound to detect this bilateral infiltrates is considered as a Kigali criteria in the Kigali modification. And the third one, it says the this respiratory symptoms should not be fully explained by cardiogenic origin. Of course, the Kigali also considers the same. And the third one, as you can see, the severity classification in Berlin definition requires that the patient should be put on the PEEP of 5 or 5 centimeter of H2 or more, that I didn't mention before actually. So, but in case of Kigali modification, there is no need to put the patient on PEEP to classify the patient's severity of hypoxemia. That is another difference. And the last difference is the use of peripheral or the SpO2 in place of PaO2 in the Kigali modification. So we will use the peripheral pulse oximetry reading from our pulse oximetry, and then we'll divide by FiO2, and the number we will make some adjustment on the numbers. That is, we said if the PaO2 FiO2 is less than 300, in case of Berlin, it is considered as ARDS, but in case of Kigali modification, when the SpO2 to FiO2 ratio is less than 315, then we will consider the patient has having a form of ARDS. That is a modification. So we have two modifications in general. That is the use of ultrasound in place of CT scan to detect bilateral lung infiltrates, and the use of SpO2 FiO2 ratio rather than the PaO2 FiO2 ratio in case of Kigali modification. So this is what we need to apply in our setup. Okay.
Yeah, thank you so far, Hussein. You are doing great. So we have defined ARDS as well. People want to know the pathophysiology as well. So can we continue with the pathophysiology?
Okay, yes. So in the pathophysiology, how does this ARDS causes the derangement in oxygenation of the tissues? How does that happen? So overall, the phases, upon the histologic study, histologic examination of the patient's lung, like in the postpartum situation, 3 phases of the pathophysiology of ARDS development were described. That is the first phase is said to be the exudative phase, whereby in this phase the alveoli will be filled by fluid. That is, there will be inflammation of the alveoli, so there will be secretion of a lot of inflammatory mediators, and fluids will be filled into the alveolar sac, and there will be a damage, okay, to the alveolar wall with concomitant vascular or cellular permeability will facilitate or will increase the the entry of fluid into the alveolus. Okay, so this results in an impairment of oxygen diffusion from the alveoli to the capillary bed, and sometimes also the microthrombus, which is a common pathophysiology in COVID ARDS especially. So microthrombus can also occur in this exudative phase. Okay, and the second phase is said to be the proliferative phase. In this case, the fluid that is entered or that is collected in the alveoli will be reabsorbed by the lymphatic system, and also there will be a repair and restoration of the alveoli capillary with the proliferation of epithelial cells, and the cells also will differentiate with concomitant production of surfactant, and also the barriers of this alveolar wall will be restored into the normal condition. So usually it's said to occur after usually like 10 days usually. Okay, the first exudative phase usually said to occur within the first 7 to 10 days, while the proliferative phase starts after the end of this days, that is after 10 days. And the third and the last phase is called the fibrotic phase. This phase is usually characterized by scarring with interstitial fibrosis, vascular fibrosis, and the alveolar wall fibrosis will scare with the storage of collagen fibers and so on. So this may result in scarring of the lung tissue with long-term consequence on the patient's respiratory function. Sometimes if it's the alveolar scarring is widespread, this may result in pulmonary hypertension, and associated complications of pulmonary hypertension can occur. So the ARDS actually progresses in these 3 phases of pathophysiologic characteristics.
Good. Thank you, Dr. Hussein. So we'll go along. Let's see a short video here, which just will show us what the pathophysiology looks like. It's a very short video, and after doing that, we'll be discussing about how to manage ARDS. So yeah, this is just a pictorial presentation of what will happen the pathophysiology of ARDS. So that's what Dr. Hussein clearly described it. Thank you, Dr. Hussein. So the next thing to see is how are we going to treat ARDS. Yeah, our the panelists, Dr. Rima, haven't yet joined us, so we'll go along with by ourselves. So one of the ways of treating a patient with ARDS is by putting a patient on a mechanical ventilator, as you know. So let's see what the next question brings for us. So can you define and discuss the goal for each of the following parameters of mechanical ventilation. So I'm sure you have put some of your patients on mechanical ventilator before, or at least you have seen patients being put on mechanical ventilator, and these are the parameters we set and we give to the patient, like the tidal volume, fraction of inspired oxygen, plateau pressure, PEEP, driving pressure, peak inspiratory pressure. Okay, these are something to be a fixed parameters which we set, or some of them are also measured parameters we measure from the patient lung on a mechanical ventilator. So can you define each and also try to discuss maybe taking one of the parameters the next 30 seconds? Yeah, I think it's too much to define, right? You can just, yeah, so I'm seeing tidal volume for 6 ml per kg of ideal body weight. So this is what we said, right? As for ARDS patients, we set a low tidal volume, a lung protective strategy. So yeah, we wanted to know also, you know, what is FIO, what's tidal volume, what's plateau pressure, PEEP. So as most of you are saying, you know, in ARDS patients, when we set our tidal volume, we want to go low as 4 to 6 ml per kg in order to avoid, you know, volume and barotrauma, as compliance of the lung could be stiff. So it's what we call a lung protective strategy. But in order to compensate for that, we'll use a higher respiratory rate to keep up with minute ventilation. So let's deal with each of the parameters, and let's go and define them together. Yeah, waiting for a screen to come. I guess we have some technical problem showing you our references. So we can go along, you know, with these parameters. As you know, tidal volume is what we say, you know, it's a volume which will be delivered through each breezes. Okay, when we breathe spontaneously, each time we are breathing normally, it's the amount of tidal volume we are generating. And this is something to be set on ventilator as well, okay? As you know, fraction of inspired oxygen is, the percentage or the concentration of oxygen you are delivering to the patient. So in terms of, what component of the air is the oxygen constituting of, if 100% of the gas we are delivering is oxygen, then our FiO2 is what we say 100%. But we are giving air, like atmospheric air, then it is, the oxygen content is 21%. So you can play in between 21% and 100% based on, using your mechanical ventilator. But the plateau pressure is, something you are going to measure. It's not something you are going to deliver to the patient, but it correlates with the pressure that's building up in the alveoli, or the pressure that's distending the alveoli. When we say PEEP, it's positive index expiratory pressure. It is a pressure that remain in our airway and lung cavity at the end of expiration. And physiologically, it's something created by the closure of glottis. But when using a mechanical ventilator, we need to have a PEEP valve, okay, in a ventilator. That's what's creating a PEEP, and it helps in keeping the alveoli in smaller airways open. So the driving pressure is something, something we calculate by subtracting, okay, between a plateau pressure and a PEEP, and this should not be, greater than 15. Okay, so whenever the driving pressure is larger, we are going to cause a lot of stretch on the alveoli, and that's what leads to a barotrauma. So in other words, the driving pressure is what's determining, or what's telling us, the compliance of our lung is important. So peak inspiratory pressure is a pressure that's built in our lung and airway system. So it has got pressure built up due to a resistance in the airway, as well as a pressure from the alveoli. So when you adapt that, that's what we call peak inspiratory pressure. So we want to keep in ARDS patients, we want to keep the plateau pressure below 30, the driving pressure below 15. And, we wanted to have a higher PEEP, a lower tidal volume. We usually start with a higher FiO2, and gradually we decrease in order to minimize oxygen toxicity. So these are the parameters. I'm sure you know most of them. So you have to memorize them as well. So let's continue with the next set of question. So it's about, paralysis, neuromuscular blockage. So it's not uncommon to put patients on neuromuscular blocker when we are managing ARDS, and we know that it has a pros and cons. So can you write down the pros and cons in the chat box in the next 30 seconds, please? So what is the advantage? Why do we want to use a neuromuscular blocker when we are treating ARDS? And what is the disadvantages? Okay, so yeah, so I'm seeing someone saying it has got a mortality benefit if it is used over 48 hours. patient ventilator desynchrony. Okay, it increased compliance. Okay, eliminate patient ventilator desynchrony. Yeah, it's the advantage, right? So what could be the disadvantage of using paralysis in ARDS patients? Yeah, I'm seeing so many pros. Thank you. So, yeah, as you said, you know, the advantage of, you know, using neuromuscular blocker is one thing, you know, to smoothen, you know, patient-machine relations. That's what we call synchrony. So it's not uncommon to have asynchrony when the patient's respiratory demand is very high and patient's breathing faster. At the same time, you are delivering a tidal volume from your mechanical ventilator. There will be breath stacking. Okay, when a patient tries to breathe, it could be the time for the machine to have expiratory phase and so on. So you want to avoid asynchrony. The other thing is you also can, you know, rest the respiratory muscle, which can exhaust, you know, the oxygen reserve. Okay, at normal physiology, the respiratory system only takes about less than 5% of the oxygen or energy reserve of the body, whereas in a respiratory failure with ARDS, this may go high up to the level of, you know, 40%, and so you want to, you know, reserve the metabolism somewhat. So whenever there is synchrony, there is a rest, then the outcome can be improved. So that's why some of you were saying muscle paralysis for the first 48 hours can be helpful in reducing mortality. But what about, you know, it is disadvantage? And I can see from Daniel, this is disuse atrophia when the muscle is paralyzed and not used for a longer period of time, then a muscle mass can be lost. Okay. The other thing is, you know, there is a critical illness, myopathy, and also neuropathy can also be developing. So I think I'm seeing Dr. Rima. She joined lately. She was having some problem, I guess. So let me invite her. Dr. Rima, you can say hello to our participants.
Can you hear me?
Yes, yes.
I didn't realize, is my video on?
Yes, you are.
Oh, sorry. I completely didn't realize. Where are we? Discussing pros and cons of neuromuscular blockade. So you've already talked about it a little bit, haven't you? Now, my name's Rima. I'm one of the anaesthetic and intensive care registrars working in Edinburgh in Scotland. I actually thought this session started at 1 o'clock UK time, so I might be a little bit late to that, and I'm really sorry. Do you want to continue for this session and then I'll
it's good. It's good. Yeah, you can continue with that. You know, how is your experience maybe at where you are working? I mean, would you use neuromuscular blockage most often? Because you know, in our setup, we don't like to use neuromuscular blockage quite often. We don't have neuromuscular blockers and we don't have ABGs. Because of, you know, we can't manage complications following that, like neuropathies, myopathies, and so on. We prefer to be on the safer side, unless and otherwise we're forced by asynchrony and the hazard to the patient, like, you know, pneumothorax and so on. So what's your experience? And you can tell us from that, and you can take over maybe with the next question.
Yeah, so basically, we tend to try not to, similar to you, try not to use neuromuscular blocking agents early on unless there is a significant respiratory issue or some respiratory indication for it. So, you know, if there is ventilatory asynchrony, or if the patient is on 90 to 100% oxygen, we would consider paralysis before we then consider things like proning. I think you have to make it relevant to your setting. So if you have limited ability to then look after the complications of neuromuscular blocking agents, I would be cautious, like you said, Ananya, of using it. I think in our setting, we are quite lucky that we can deal with any sort of complications, any sort of neuropathies, and we can give patients tracheostomies and prolonged ventilation as a result of it. And there are obviously advantages, there are physiological advantages of neuromuscular blockade, but I would be cautious in that we know that there is no mortality benefit, although it does reduce the number of days on an ICU ventilator. So I would be cautious about it, but there are clear clinical indications for it.
Thank you, Rima. Thank you. So I think we can proceed to the next set of management peers in ARDS management, is fluid management. So Dr. Rima, you can go along with raising the question.
Sure. So the next question is, should we aim for liberal or conservative fluid strategies? So I will give you a couple of minutes to think about that question and put your answers in the chat box, and then I will pick up on some of that in about 30 seconds to a minute. Type quickly. So already I'm seeing a lot of conservative fluid strategies. Conservative with a target of negative balance. And I will give you another 30 seconds before we discuss it. Better to keep the dry lung, conservative management. So I think everyone is of the same or similar opinion that a conservative fluid management is better than overloading the patient. And that really was based on the paper which was published in the New England Journal of Medicine. And it discussed the comparison of fluid restrictive management versus fluid liberal management of acute lung injury. And what they found is that although there was no overall improvement in mortality with a fluid restrictive management of the lung, there are an increased number of ventilator-free days and ICU-free days. And I think especially working in your setting, it's probably important to try and keep the patient off a ventilator, try and keep the patient self-ventilating without an endotracheal tube as much as possible, I would say. So we know that especially in acute lung injury, or especially in ARDS, we know that the lungs or the alveoli get leaky, the capillaries get leaky, and any sort of increased fluid within the intravascular space can then leak into the alveoli, and that can worsen your ventilation perfusion matching. It can worsen the way you get oxygen into the alveoli and carbon dioxide out. So overall worsens gas exchange. And that's the physiology behind why we go for more of a restrictive approach than a liberal approach. So I would urge you all read this paper because it is an excellent paper. What you can see on the screen was Ananya showing you the protocol, and it is quite a complex protocol. So what they looked at was they looked at central venous pressures, and there were different algorithms to follow based on whether the patient was randomized to a fluid restrictive strategy or fluid liberal strategy. So it was quite a complex protocol, but essentially the message was that a fluid restrictive strategy is better than liberal fluid. Does anyone have any questions about that? Or does anyone want to talk about their own experiences with any specific cases? Feel free to type any specific cases or questions in the chat box, and then I'll try and answer them either during, when I'm waiting for your replies, or afterwards. So that's fluid management. And again, like I said, make sure you all have a look at those papers. So we'll move on to the next section, which is looking at prone positioning in severe acute respiratory distress syndrome. So when should prone positioning be used, guys? Type in the chat box. Right, why don't you all type answers to all of these questions in the chat box? I'll give you 30 seconds, and then we can maybe watch the video. Ananya, what do you think?
Yes, good. Let them try something on the chat box, and we'll see the video.
Okay. So we'll give you all a couple of minutes to answer these questions. So we're talking about refractory hypoxemia. Yeah. In which patients? And also try and think about whether there are any absolute or relative contraindications to proning. Yep, so if oxygenation doesn't improve with maximum support, why don't we move on to which patients you would, how is it done? So type in the box, how is it done? And then we'll watch the video. Yeah, moderate severe ARDS, refractory hypoxia, refractory hypoxemia. How is it done? It's quite a long thing to type in the chat box, actually, isn't it? Can be done after a patient is informed about it and manpower is adequate. Yep. Patient in shock state is contraindicated. Let's talk about that afterwards. Contraindications include pregnancy or spinal instability. Again, let's talk about all of these things afterwards, because these are really important things that we need to really take into account. Placing pads on the chest and thigh area. Okay, yeah. Shall we watch the video, Ananya? And then
yes, exactly.
Proning an ARDS patient receiving invasive mechanical ventilation in the ICU must be done carefully to ensure safety during the procedure. For the procedure to be successful, it is vital to use trained and experienced staff. The video you are about to watch shows the technique used to achieve the prone position and the return to the supine position. The procedure usually requires 3 to 4 people. One person remains at the head of the bed to secure the endotracheal tube and the ventilator lines. This person coordinates the procedure. The other people position themselves on each side of the bed. The procedure is performed following 5 steps. The first step is to prepare the procedure. At this stage, you have to decide which direction to turn the patient, to the left or to the right. Priority is given to whichever side the central venous lines are located. Check the length of the vascular lines and the transcutaneous saturation cable to be sure they are long enough. Move the ventilator as close to the patient as possible. Check the patient's hemodynamic status and the level of sedation. Secure the endotracheal tube and the gastric tube. Protect the skin on the forehead, knees, iliac crests, and thorax from pressure sores using adhesive pads. Protect the patient's eyes and get the electrocardiogram electrodes ready for use. The second step is to move the patient horizontally. Then they are moved towards the opposite side. From the side they will subsequently be turned towards laterally by pulling the bedsheet. The patient should be moved towards the side of the central venous line. After moving the patient sideways, the hand on whichever side they will be rotated onto is placed under the buttock. A new bedsheet is also prepared along the length of the bed. The third step is a side lie. The patient is rotated laterally in a full side-lying position. The patient is maintained in this position for a short time while one person removes the electrodes from the anterior thorax and another person attaches the new electrodes to the back. The fourth step is complete pruning. The new bedsheet is used to pull the patient and to move them into the final complete prone position. The body is placed in a horizontal position at 180 degrees. The abdomen is usually not supported. The upper limbs are placed alongside the body. The fifth step is post-proning installation. The patient is moved to the center of the bed. The head is turned laterally and moved every 2 hours. The endotracheal tube must be easily accessible. Care should be taken to close the eyelids tightly and avoid ear kinking. To move the patient from the prone to the supine position, the steps are as follows. The first step is to move the patient horizontally towards the center of the bed. The second step is a side lying on the same side as in step 3 of the proning procedure. The patient is maintained in this position for a short time while one person removes the electrodes from the posterior thorax and another person attaches the new electrodes to the torso. A new bedsheet is also prepared along the length of the bed. The third step is a complete supine positioning. The new bedsheet is used to pull the patient and to move them into the final complete supine position. To summarize the key points of the procedure: trained and experienced staff, 3 to 4 people, good preparation of the procedure, horizontal move, side-lying position, complete proning, and post-proning installation.
So you've all seen how it's done, and interestingly, in the UK, so where I work, we wouldn't really consider proning if we didn't have at least 6 ICU nurses. But in your setting, you need to, and that's why they've shown you the way that they have with 3 people. We sometimes just need to make do, and if the patient needs proning, then the patient needs proning, right? So you guys have talked about refractory hypoxemia, And I think that's exactly why you would prone. So there was a paper called the ProSEVA trial, and that was again published in the New England Journal of Medicine. And that essentially showed that there was a mortality benefit at 28 days and 90 days with proning. So we know, especially with COVID that has gone on in the last 2 years, we know that not only asleep proning, but awake proning is of benefit to our patients. And you might be able to see that straight away. As soon as you prone someone, their oxygen saturations will improve, their BQ mismatch will improve, and their oxygen requirement will go down. So there's benefits in that, whether the patient is awake or asleep. And I would really urge you to read this paper because it is a landmark paper in intensive care medicine and critical care medicine. So we talked about how it's done. So I'm not going to go into exactly how it's done because you've seen the video and you've talked about padding pressures and looking at making sure your pressure areas are okay. So when we talked about contraindications, including pregnancy and spinal instability, so interestingly, in my unit, we've not done it where I work, but down south in London, where they do a lot of proning, they do a lot of extra corporeal membrane oxygenation, especially with COVID. They found that it is possible to prone pregnant women as long as you've got the right beds, you've got the right number of pillows, you've got the right number of training to allow for that. So although we would generally not prone pregnant women, it is possible if you have the right number of staff, resources, and equipment. And yes, you've talked about spinal instability, and that's definitely a big consideration with proning. And I wouldn't go proning people if they have spinal instability. Someone's talked about patient in a shock state is a contraindication. I will say it's probably relative and not a complete contraindication. If we talk about our A to E assessment of critical care, so you think about your airway first, you then think about your breathing, and you then think about circulation, and you think about what is more likely, probably less relevant if the patient's already intubated, what is more likely to kill the patient first? Is it going to be your breathing or is it going to be a circulation? If the patient is on enough vasopressors to be able to maintain a good cardiac output, to be able to maintain a good blood pressure, I wouldn't say it's a complete contraindication to not prone the patient if they are in refractory hypoxemia. But equally, you need to be aware that significant vasopressor use is going to affect your is going to cause pulmonary vasoconstriction, and that can maybe counteract some of what you're trying to achieve with proning in terms of VQ mismatch. So just have a think about that, and I would take it on a case-by-case basis, as opposed to saying a blanket, no, that's going to happen, that's not going to happen, or a blanket, yes, that is definitely going to happen. So you always treat the patient in front of you. So the next thing is pulmonary vasodilators, and that's it's quite an interesting topic in critical care. I'm sure those of you who have done lots of research or have been working in critical care, it's quite it's a topic of argument and discussion in intensive care. So we'll go with the question. There is ample evidence that inhaled pulmonary vasodilators improve mortality. So true or false, guys? So the results are in. 20%, oh no, it's changing, it's changing. So I can see that only 15 out of how many people have replied. So if you see it, please, please, please do answer the poll. I'll give you about 15 more seconds and then we'll move on because I could watch these numbers move all day. Got a few falses in the chat box. So I'm going to end it there. We have 18 out of 47 of you participated, with a few in the chat box, but essentially the consensus from you all was that this statement is false. There was 28% that said it was true, but the majority said it was false. And I'd like to reveal the answer, which is actually that it's false, that there is not ample evidence to suggest that it improves mortality in ARDS patients, in severely hypoxemic patients. So there is no data, in fact, to suggest that there is an improvement in mortality. But we know that using stuff like prostaglandins, using nitric oxide can buy you time. So what I found, especially in COVID, we've used it a few times in patients who are in severe respiratory distress, and we used it as a last line therapy when we have nothing else left. And we were aware that it would not improve mortality, but what it can do is buy you time. And when I say buy you time, it buys the patient's time, the patient themselves time, so that they can try and overcome the physiological insult that they're experiencing. So don't forget, critical care is primarily about buying patients time for their own physiology to recover. And we augment that and we support that, but it is all about buying patients enough time for them to sort themselves out. So I've used nitric oxide, again, as a last line therapy. That patient died. Equally, I used nitric oxide in another patient who had COVID as a last line therapy, and that patient survived. So I wouldn't say that it was the nitric oxide that saved them at all. And I think some people will try it, some people won't, because there is no research to suggest that it helps. But I don't know, Ananya, have you used it a lot in your practice?
No, we haven't used the pulmonary vasodilators so far. One thing is availability. The other thing, as you said, is there is no evidence supporting that. So we are not utilizing, but in the future, maybe. We don't know how it's going to be changing, how the science is changing. This may come as a recommendation.
Yeah, it's difficult. And when I have used it, it's been really difficult to get hold of. The only people in our hospital that had it was a pediatric anesthesiologist. And then trying to fit the actual nitric oxide cylinder into your circuit, your ventilator, it was quite difficult. And we had to read the instruction manual, and it almost wasn't worth it. The time it took us to get and then get it working, I'm not sure if it was worth it. But again, I would make sure that if you are using it in whatever setting that you are, and you do have access to it, make sure you're properly trained to use it, because you don't want to be making mistakes with the circuit or with the ventilator, especially if the patient's on 90 or 100% oxygen. So just be careful if you are going to embark on pulmonary vasodilators. So the next thing is a small breakout session. Is that right, Ananya?
Yeah, so because we have covered now all of our objective, what we started, defining respiratory failure, hypoxemia, ARDS, and later how to treat ARDS, so different strategies, mechanical ventilator, and issues with, treatment of ARDS, like the fluid management, and the prompt positioning and so on. So now we'll end up the session here, but we have a 5 minutes breakout session, and it's going to be each participants will be divided in a small group, and the panelists will join them, so that participants, you can ask questions, and we can discuss for the next 5 minutes together. So can we Can we get that from the eco team as well, the breakcast session? But until then,